Thank you so much. As she mentioned, my name is Michael Hull, and I have the great privilege of being on the stage today with two remarkable experts in their respective fields, and I'm excited to hear from them today. I want to tell you a bit about the work that I do very quickly, and then I want to set the stage for why it is that we're all here before we dive in to your presentations. So I'm at the University of Texas at Austin. As she mentioned, I'm faculty at the Dell Medical School as well as the LBJ School of Public Affairs. And I have the best job in the world because I get to do three things. The first and foremost is that I'm a street doctor. So I'm a pediatrician for children experiencing homelessness in our community. My doctor's office is on wheels. We take it to the places to find and care for our hardest to reach and most vulnerable patients around the community. I love that part of my job because, one, I get to love on these kiddos and families, but also because it's a really privileged window into the struggles that families are facing, as well as the programs and policies that are trying to address those struggles and whether or not they're working. It's an opportunity to bring the people actually facing the problems we're trying to solve into the decision-making process. My second job is as a professor on campus. I teach public policy, human-centered design, and entrepreneurship, and so a lot of the work that I do is developing empathy with the communities we're trying to serve so that we can develop solutions that matter to them and not matter to us sitting in the ivory towers. And then how I spend most of my time is as executive director of Financial Health Studios, which is a hub for health systems innovation and entrepreneurship at the university that is bent on increasing people's incomes and decreasing their expenses as a means to improve their health. We heard a lot in the lunchtime talk around how at the root of so many of these social drivers of health, and we'll get into that in more detail, is money. If we really want to solve a lot of these issues, it is workforce development at the core of how we're going to improve health. I've been asked to set the stage today of why I'm here and also why all of us are here, and I want to bring in the story of a little girl I had the privilege of taking care of in order to do that. I met Chloe several years ago now, not in this state, because she was brought into my preceptor's office by her kindergarten teacher. She had noticed that earlier that day at recess, little Chloe had some bruises on her arms and legs. The teacher was worried that she was being abused, and so instead of letting her get on the bus, she brought her to the pediatrician. And I can remember little Chloe pretty clearly because she had this bright pink and purple blanket, Cinderella, I think, and she would take it from her lap and put it over her head while I was trying to listen to her heart with my stethoscope. And we pretty soon found out that in addition to those bruises, she also had some swollen lymph nodes, she had some gum bleeding, she had some recent weight loss, she had all the telltale signs of cancer. And in fact, she had acute lymphoblastic leukemia, or ALL, which is childhood's most common type of blood cancer. That's a cancer that, until the 1960s, was a death sentence, and then we discovered this drug called vincristine. And today, if you get ALL in the United States, your likelihood of cure is upwards of 90%, unless you are poor. So when little Chloe was diagnosed, her father was incarcerated on drug charges, her mom was working 2 jobs to make ends meet, and she was really struggling. She was behind on her rent, and her landlord was on her case. She was behind on a couple of her utilities bills, and her electricity kept getting shut off. Her car was broken down. She didn't have the cash to fix it, so she was relying on public transportation to get to and from her 2 jobs. And as you can imagine, public transportation isn't always very reliable. So she was late to work. Her boss was on her case. And to make matters worse, the pediatric oncologist, rightly so, said that little Chloe's body would be better able to tolerate the chemotherapy and fight off the cancer if it was better nutritioned, if she could start to buy some of these expensive, healthy fruits and vegetables instead of some of the fast food and canned fruits that she was able to get from the food pantry. So as you can imagine, Chloe's mom was very stressed, and then she made what is to this day one of the most heart-wrenching decisions I've seen a parent have to make. I'm an expecting dad. My wife is due in about 6 weeks. She sent her daughter with cancer to live with relatives who happen to live in a crowded public housing unit so she could take on a 3rd job to try to save up the money so that she could be, in her words, the kind of mom Chloe deserved. Chloe, in that place, with another family of 4, slept on the floor on that same Cinderella blanket, and with a weakened immune system, caught a preventable infection and never made it to first grade. I tell this story today not to create a somber atmosphere in here, but to ground us in the reality of the struggles that families are facing. Some of us in this room may have faced those before. I want to call us to work together, and in this discussion have a solutions-oriented discussion around how we come to these conferences and meet all these people from across sectors and start to build solutions so that no other child in the United States of America, or anywhere really, has to face that kind of injustice. So that every person in the richest country on earth can grow up and reach their full potential. So a lot of those problems you heard about with Chloe's family, transportation and food and income, those are what we call the social determinants of health. And so I'm really privileged to turn it over to Ruth to tell you a little bit more about what those are and how they're tied through the evidence to health outcomes.
Thank you very much. Can you hear me? Can you all hear me clearly? Okay, great. So yes, my name is Ruth ThomasSquance. Thank you to the organizers for inviting me here today. It's great to join you at this exciting meeting. I'm just going to say up front, if anybody's sitting there wondering, is she Australian? Is it South Africa? I'm originally from the UK. That's my accent. And inspired by Calvin to share a fact that you may not know, that I actually grew up, it's not in the bio, I grew up in rural Wales. And I trained I have a PhD in biochemistry, so I trained in biochemistry and genetics and doing cancer research before I transitioned to public health. And so today, I'm the director of field building at the Build Healthy Places Network in San Francisco. I should get this ready. And we're a nonprofit organization, and we really work as a national center at the intersection of community development and health. And really our mission is to shift the way organizations work across those sectors, across health, community development, and finance sectors, to really sort of with 3 aims: to advance equity. Oh, I suddenly got a lot louder. Was that just me? Reduce poverty, and then also improve health in neighborhoods across the US. So I know some of you have a sense of the role of place in health, but I'll reiterate some of the information, make sure we're all on the same page. And so this graph really is just showing that there's generally a relationship between the amount of money a country spends on healthcare and then the life expectancy that the individuals in that country can expect. And just without knowing much, just following the red line, it becomes pretty clear from this graph that the US is an outlier in this. We spend a lot more than any of the other countries on healthcare, but yet the American population has not a longer life expectancy, but actually shorter than a lot of other countries that are spending a lot less money. And if we look at the problem in more detail, what we say is that the US is spending about $3.8 trillion per year on healthcare. Oops. And the majority of this is on chronic disease, and over 85% of the costs go on chronic disease. And most chronic disease is preventable. As Calvin was talking about, things like asthma, even diabetes and heart disease can be preventable. And another fact is that low-income individuals living in low-income environments carry a disproportionate burden of chronic disease. And so what this calculates out to be is about, we're spending about $1 trillion per year on avoidable chronic disease occurring in low-income neighborhoods. So we're sort of talking at a considerable scale here. And I tell you this not really just to sort of persuade you that it's important. I think that all of you being here today is indicative of that, but to really look at what is the cost of inaction? What is the cost of us not doing anything and not forging these new approaches and looking at new partnerships to change the scenario? So to go back to what we mentioned earlier, the definition of health as being a state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. And we've known this for quite a long time. I mean, this was framed by the World Health Organization back in 1946. But yet, sort of 95 to 97% of our the money that $3.8 trillion is really focused on health care. A small percentage is focused on public health. But yet what we know, what research has shown us, is that healthcare really impacts a small piece of the pie of what controls, what impacts our health. So there are all these factors like the built environment and other factors that are really feeding into the health of our population. And the effects are quite profound. So we've heard a little bit, we heard some really interesting discussion earlier today about dealing with educational inequities and addressing that. And this shows that this is all tied in also with health. If you look at the life expectancy of men at age 25, there's about a 10-year differential between those that have not graduated high school and those that have got a college degree. We can also see health is also income. If you just sort of looking at this graph, if you just sort of follow those green arrows, you'll see that there's an increase in poor health the closer you get to the federal poverty level. So there's about a 3- to 4-fold difference between the highest earners and the lowest earners. And this happens across racial and ethnic groups that we've got split here. So there's a general pattern that the more money you have, the better your health is. But while I'm saying it, that happens across racial patterns, I think it's really important to remember that poverty is concentrated in certain sectors of our society. And so while we've got, twice as many black and brown adults living in poverty as their white, non-Hispanic counterparts. And in children, that being a sort of a 4- to 5-fold difference. And what we heard from Richard Rothstein earlier today is that we have created environments that are defined by disinvestment and have concentrated poverty along racial lines in certain areas. And so when this plays out and that we see disparities in health disparities across racial groups, we should really also be thinking about people who are forced to live in environments that don't support their good health. So we know health is education, health is income, and we know that people get sick because of their social and physical environments. And there are all these factors: the built environment, access to foods, safe and affordable housing, economic development, as Michael mentioned. All these things impact our health. And they're called the social determinants of health. And that mouthful of words is what we've used to describe this whole set of factors that impact our health long before the healthcare sector or the healthcare experience is even involved. So there are things like we've mentioned today, sort of poor nutrition. These are negative. This is a list of sort of negative impacting social determinants of health. Things like homelessness, family violence, and just generally poverty. And there's sort of very sort of aggressive looking arrows that are poking at the baby is sort of kind of intentional. In the research has shown, what we know is that these things actually get under our skin. They actually have an effect on genetic predisposition and have effect on the outcomes of our health. And so this brings us to the sort of adage that your zip code can have more impact on your health than your genetic code. And this is sort of perfect setup. Thank you to Calvin for setting me up with this. We hadn't actually agreed, but Richmond, Virginia, and we're talking about those heat maps. And this can play out when you're looking at this. So the life expectancy, the highest life expectancy, I think, is about 80 or 83 years. And that's really on a par with the countries with the highest sort of life expectancy of league table of life expectancy, as it were, globally. So we're talking about sort of Singapore or Switzerland. And in the same city, just 8 miles away, the life expectancy of 70 is slightly below the average life expectancy in Bangladesh. So all that is happening in the US, in the same city. And this really sort of very profoundly shows the overlap with some of the environmental and the climate sort of change concerns that we could have. I think when I was looking at Calvin's map, this pretty much overlaps with the heat map that he was just talking about. So the impact really is actually impacting people's life expectancy. And this can also happen over a really short distance. We also heard a little bit about Minneapolis earlier today, that you can have such a short distance where there's a 13-year difference in life expectancy over 3 miles. So that's 4 years per mile over one area. So we know that healthcare needs to address some of these social determinants of health, and healthcare is really very experienced and expert at delivering healthcare, thank goodness. They're also very good at addressing social needs. A lot of healthcare systems now are doing interventions where they will address the social needs of their patients. And I just wanted to make a quick point here while we're talking about addressing social needs versus social determinants. They are both very important. And so when the hospital is sort of interviewing some of their patients and sort of surveying them for some of those factors that we've talked about earlier, sort of like housing, access to food. They then use that data to sort of inform care and then also make referrals to maybe some community-based organizations to try and connect those patients. And that's a really individual level impact. So you might have things like hotspotting, where you identify your high utilizers of your system, quite often people experiencing chronic homelessness, and you're addressing those needs. And the problem being that you're not really changing the group of people that are moving towards that problem. In a year's time, who are your new high utilizers going to be? And so what we're talking about here today is really addressing those upstream, what we call community impact, social determinants of health, that are trying to have a broader impact on all those environmental conditions affecting health, and basically affecting your zip code on a community level. And so, the good news is that basically the everyday work of the community development sector is essentially the zip code improvement business. And so by addressing affordable housing, sort of supportive housing, healthy foods in an area, they're really sort of intervening upstream in those social determinants of health that we want to get to sort of change a population level action. And also they work across the life course, which is a term from public health, because you're thinking of families, you're thinking of future generations, possibly older people. And so by combining that upstream and also being able to work across life course, that makes for a pretty impressive and powerful prevention system. And this is just my favorite tweet from this year, from Valentine's Day. Roses are red, violets are blue. Patients don't have social determinants of health, communities do. As a reminder, so that we can always think that we're not talking about an individual level, but we're talking about a community level. So in order to do this, healthcare really needs new partners. And I'm just going to quickly, I don't know what we're doing for time, but just quickly go through some examples. And because Robin is going to get much more granular about sort of how we can shift and scale investment to mechanisms to make this work. I'm just going to skip this one. So this one is from the National Children's Hospital, working with a community development for all people, and that's based in Columbus, Ohio. And as part of their group, it was healthy neighborhoods, healthy families, Realty Collaborative. They invested in a housing redevelopment, but also with a workforce development element in that the residents was walking distance from the hospital, but they also trained neighborhood residents for jobs in that hospital, so that they Okay, there we go. They used some of their own investment and so their community benefit dollars, but to sort of co-locate, in this instance, the residential and the economic improvements. This one's ProMedica, a health system based in Toledo, Ohio, who worked with LISC and launched a pool of $45 million in the form of grants and loan funds to scale up economic opportunity that also improved outcomes, health outcomes in that area. And that's a sort of really significant, meaningful amount of money in Toledo, Ohio. And finally, this is Dignity Health System, had an investment. They set up a loan fund, which as part of their investment portfolio, and used to provide direct low interest loans. And one of these, because this is a non-housing solution, but the Children's Museum of Phoenix, which was then able to provide a service through a 1.5 million loan, and also invigorate a low-income part of town. And so the good news is that community development and healthcare are perfectly primed to work together. They often work in the same places, often with the same people. They're able to intervene. Community development offers an opportunity to intervene at the neighborhood to really address those social determinants of health that underpin our population's health. They bring financial expertise and substantial resources of their own. And it really gives healthcare an opportunity to accelerate their positive impact. And the Build Healthy Places network, we act as a sort of at the intersection of this cross-sector investments to sort of speed and spread innovation, provide tools and facilities for people to make those new partnerships, and sort of accelerate some of that health dollar investment into social determinants of health. And this is our website, and a lot of the resources are available on our website. And oh yeah, this is my product placement. I brought some of these some of the things we're talking about, like the jargon buster, etc. I think it's available on that table. And a community development playbook, which is a sort of a playbook guideline for community developers on how to approach the pretty complex health system that we have to know who and when and how to approach people. And I can move forward. And these are just some of the things that are on our website, and also resources, which is another product placement for the Urban Institute that spoke earlier, which wasn't planned. Oops. Oops, thank you. So thanks very much.
Great. So I can barely see you all, but I'm going to try to bring us home at the end of the day by talking a little bit about some work that we've been doing over the last 6 years since I was last in Austin working with some of you to try to figure out how do you bring together the different kinds of stakeholders that are required to really make a difference in this work. And it would help me tailor what I'm going to say to you if I can just have a show of hands for how many of you are going to be housers, health people, finance people, or community. So how many of you are housers or think of yourselves as being housers? How many of you are from the health sector? Okay, how many are in finance one way or another? Who are you all people? There are no hands going up. And how many of you are community? Okay, other? Lots of other. Okay, perfect. Well, we'll do what we can do. And I'm happy to take questions once we have a chance to get through some of this. So what I'm going to try to do in my remarks very quickly is give you the outlines of an approach that we have been refining at the Center for Community Investment and look at how these different sectors can come together to make a difference. And my goal, if I am successful, is that everybody walks out of here with at least one specific thing, an idea, an action that you can take in the next 30 days in your role. Because it turns out that in this work, there are many, many opportunities to lead, and formal and informal authority both tend to be good places. So a lot of this, I think, follows very directly from what we've been hearing all day, which is the well-being and health of our communities really depend on how we invest in them, how we invest in them at the level of government, how we invest in them at the level of community, and how we invest in them as individuals. And the normal ways that capital flows into communities tend to reflect market and policy decisions, market more automatically, policy more intentionally. And we can change those things by redirecting the flows to make them more equitable. And that's really what we're going to have to do if we want to overcome the legacy of structural racism and discrimination that we've been talking about all day. One of the things that we find when we talk to people about doing this work, especially people who don't come from finance backgrounds, is that we talk about investing in community or investing in our children as though it's kind of a poetic exercise. And what I would encourage us to do is, that kind of investment is important. I have kids and everybody wants to invest in our future. But what we're talking about here is finding the ways that go beyond grant dollars, that go beyond government subsidies, to try to mobilize capital which exists in much larger pools in our country. And as long as we're just thinking about spending and grants, things that cannot be monetized or returned, we're only using a fraction of the assets that we should be mobilizing to deal with what are really some very, very large transformational changes. So I'm going to encourage even those of us who are not finance people to think finance, and I'll try to lay out how to do that. So in this little chart, you see what are some of the ways that we can change health by making grants on the left, and what are the ways that we could do it through investment. So if you think about housing, referrals to affordable housing would be spending, but creating or preserving affordable housing units would be investment. Investing, spending to a food bank so that they can pay salaries, that would be spending, but helping to finance a grocery store in a food desert would be investment. So both are important. It's not one at the expense of the other. It's how do we mobilize all of the assets that we have to make a difference. So when we do our work, we really try to change the paradigm, the practice of community investment, to make it both a more scaled and a more effective way to finance community priorities. What we find is that people walk around with the paradigm of doing individual deals one at a time. And why do they walk around with that paradigm? Because these deals are significantly heroic in their execution. There are lots of adventures and traumas along the way. I got my tax credit, I didn't get my tax credit, my investor came in, my investor didn't come in. And so the people who are used to doing these deals tend to really think of them one at a time. Then they go home, they rest, and they do another one. And we're never going to get to the scale of impact that we're looking to achieve if that's the way we go at it. So what we're suggesting in the approach that we are encouraging people to take is that we think of community investment as a system, and we think systemically about what are the functions that need to go on in that system that all of us can affect so that we get to a bigger solution. And there are really only three, and they're pretty simple, and I'm just going to walk through them quickly, and then we have lots of materials online where you can learn about what does this look like in different communities. So the first is shared priorities. We have to agree on what are we trying to do. I'll talk about that more in a minute. The pipeline is we have to be building the projects and the deals that allow us to do the thing that we said we wanted to do. And then the third is the enabling environment, which is the context in which we're operating, which either helps us or gets in our way. And if we're not working on strengthening that enabling environment, the policies, the data, the relationships that get us on our way, then the next deal is just as hard as the last one. And that's not going to get us there. So what does it mean to work on shared priorities? Shared priorities don't mean that we spend many, many hours in meetings to agree on the fact that we need good things for all God's children. And that tends to be the place that communities start from, because we don't want to annoy anybody, and we want to be inclusive, and we want everybody at the table. But those kinds of priorities are not specific enough to mobilize investment. So what we really need to do is to get to something that sounds more like, over the next 5 years, we're going to commit to preserving or producing 10,000 units of housing that are affordable to people with AMI, adjusted medium income, of less than 80%. In a couple of places, we're going to prioritize these places. And then once we've done that, we'll do something more. But if we don't make those kinds of choices that allow people to understand clearly how can they contribute to moving the goal, then we're dispersing our efforts in ways that don't really make a difference. A little bit here, a little bit there, all the city council members get a little something, but we don't actually have a concentrated impact anywhere. It's not good enough. So the first function that really needs to happen to mobilize investment for good health is we have to agree on what we're trying to do. The second thing is we have to surface the deals and opportunities that would allow us to really move the needle. And what we find, especially when we work in the country around affordable housing, is that everybody is working on whatever they're working on, and they have no idea what anybody else is working on. And so we don't take the opportunity to understand the patterns and the difficulties that are in the system. So one of the things that we always ask people to do at the very beginning of an effort like this is to sort of put the toys on the table and say, what do I know is happening? What am I personally working on? What do I know a market rate developer is working on? And how do we put that together into a picture of where things are moving and where they're stuck, where there's enough and where there's not enough, and what are the things that are really getting in our way? Which gets us to the third piece of assessing the enabling environment. The goal here is we're trying to make the next batch of deals that we do easier than the last batch. And it's not just about changing zoning or changing the code or changing policy. Sometimes it's really as simple as taking a policy that's on the books and activating it. We're working with 6 hospital systems. I'll tell you about that more in a moment. One of them is Kaiser Permanente, and they've designated the geography of the Purple Line in Maryland, which is a light rail corridor that's just being built out now, as their geographic priority. One of the things that they learned when they sat down to talk with people about the enabling environment along the Purple Line is that Prince George's County, which is where this line is going in, has the right of first refusal so that if any naturally occurring affordable housing or subsidized expiring units are coming onto the market, Prince George's County has the right of first refusal to actually buy those units. That right, which is very important, has been on the books for 3 years. The Purple Line is coming. It's supposed to open at the end of next year. It has not been exercised a single time. So it's not a matter of getting the right policy. We have the right policy. It's a matter of changing the practice, which can be done, frankly, with a stroke of a pen, to get that practice implemented. So what does it take to get it implemented? First of all, somebody had to be making a phone call that said, hey, you know, we want you to be getting in the way of a developer who's about to flip that property and make it into something expensive. Well, the voices that are interested in getting in the way, or not getting in the way, are the voices that the county had been hearing. So mobilizing the voices that the county had not been hearing, which I think Calvin was talking about very powerfully, was really an important piece of saying, hey, you know, there are people who care about preserving the communities, which are Latinx communities, that are living along this line. And we would like to be able to stay, and we would like to make it possible for the county to have the backbone and the finances and the expertise to exercise a right that we fought for and got for you. And so I'm delighted to say that on the enabling environment front, the county now, in the last month, has exercised that right of first refusal twice, and 370 units of affordable housing that would have gone away are now likely to be preserved as affordable. So there's all kinds of strategies for doing this, but in order to exercise those strategies, you have to really begin to get a sense of what the opportunities are. Where does the pipeline get stuck? Sometimes it's as simple as looking at all the different sources of support that are required to put together an affordable housing deal and realizing that the application deadlines actually come in the wrong order. And we have to get them in the right order so that in order to have this resource, you need to have that resource, but the application deadline for that one comes later. So you know what? We can change those application deadlines. If the developers are not talking to each other and to the people who control the deadlines, which very often they are not, then there's no way to even know that that's an issue. So the enabling environment conversation is really all about how do we make our lives easier by doing the things that are going to make our deals easier to get done. So let me tell you a little bit, as I was saying, about this program that we're doing with 6 health systems. What we found is that right now, in most places, including I suspect here, The people who care about housing, who care about community development, who care about health, are active in silos, and they're a small subset of the people who could care and who could matter. And very often, in most communities, hospitals and health systems who do care about community health have not been at the table for these discussions. It's unusual for them to go outside the four walls and outside the bounds of medical care to look at the social determinants of health and take them on. And I think it's fair to say that over time this behavior is going to become the normal practice, but we're still at a place in the curve where the folks who are doing this are the innovators, the early movers, and they include all different kinds of hospitals. So we're working with Kaiser Permanente, giant integrated system that includes both a health plan and a provider, a set of doctors. We're also working with Boston Medical Center, which is a very resource-poor safety net hospital, takes care primarily of people who are receiving Medicaid, has very limited resources, but a very, very high mission alignment with this kind of activity. Nationwide Children's Hospital, which Ruth mentioned, is one of the participants in our program. They say that for them, their mission is that the patient is the neighborhood, because they know that the kids that live in hotspots, in the places that were on the maps that you've been seeing all day, those are the folks who are getting medical care that should not be necessary. And that not only is expensive, which is one problem, but it's contributing to health outcomes that really ought to be significantly better than they are. So everybody in the program has chosen a geographic target. They've made a commitment to going beyond the innovation that they've already done, because they're not in the program unless they've already invested upstream. And we're learning with them not only what did it take for them to get as far as they've gotten, but also what does it take to do more. So what we've learned, What we've learned is that there are a number of different kinds of assets that health systems can leverage for this work. There's something called community benefit dollars, which are grant dollars. Any nonprofit hospital has an obligation to provide community benefit. All kinds of things count, including things that you wouldn't think would count, like uncompensated charity care, which in Texas is a thing because you guys have not yet expanded Medicaid, I understand. But also educating residents and research and all kinds of things that have maybe a community benefit, but not very direct. But getting the folks who control the community benefit money to think about what they can do to invest in affordable housing, to invest in the social determinants of health, is one source of money that hospitals can put into this work, and we're seeing that there are a number of hospitals that already do that. But then there are also other sources. There are investment assets, there are insurance reserves, there are pension funds and endowment assets and other kinds of money that has to go for investment with at least a return of the capital that was put in, and maybe a modest return, that really, if we think about targeting the finance people and not just the community benefit folks, gets us into a whole other number of zeros when we're talking to the health systems. We also have learned that many hospitals and health systems have land and facilities that can be used for affordable housing or for senior housing, that can be either donated or leased. And we found in many cases, because these health systems are large institutions, that the community benefit folks who know the affordable housing goals have never had a conversation with the real estate department who knows about the parcels that the hospital is about to sell off. And those kinds of silo-busting conversations can go a very long way. So we have 3 of the 6 health systems that are working with us now have identified land that they can use for this purpose, and they're in the process of talking to the community groups that they can donate or lease that land to. So that's another important one. And then there's expertise. One of the things that health systems have to do is called a community health needs assessment. It happens once every 3 years. And it's kind of like anything else. The questions that you ask determine the answers that you get. If what they are doing in that CHNA is asking about disease, then the answers are about disease. But if they're asking about housing needs, if they're asking about community conditions, and those come back as the answers, then they have the freedom in the community benefit department to respond to those needs in a way that, quote, counts for the IRS. So there is an opportunity for public comment anytime a hospital needs to do a CHNA, and one of the things that you can do coming out of here is figure out when was the last time the CHNA of your local hospital was done, when is the next time that it's going to be coming up, and how do you, from your standpoint, get involved in that? It's all public, it has to be on their website, and if you look for it, you can find the last one, which will help you figure out how to talk to the hospital about what they might be doing with you and for you. And then the last piece of what we see the hospitals have is relationships and influence. And that turns out to be both a great benefit and a great motivator. So what we found is that when the health systems think about social determinants, they're not only thinking of it in terms of their mission to improve health, they're not only thinking of it in terms of economic return on investment, they're also thinking of it in terms of political and reputational capital. And so if they need a zoning variance to expand their campus, or if they need a service approval to get into a new kind of business, then making sure that they're doing things that the mayor or the city cares about, that the community cares about, becomes a very, very high institutional priority. That motivation is something that you, as people working with the health system, really need to be aware of, because it helps you figure out what can you ask them for. So what does it look like in action? This is a different way of the nationwide Columbus story. You saw a picture of some of the buildings. This is a picture of their capital stack. The capital stack is the layer cake that they've constructed to put together money from lots of different stakeholders to create more affordable housing and preserve affordable housing in the South Side neighborhood that you saw a picture of earlier from Ruth. What the hospital did here was give a $1.5 million guarantee. Did not cost them a dime, because all they had to do was say, if this goes bad, which it won't because it's well structured, then we will guarantee to help make sure the banks get back their money. So there's a lot of history, 50, 60 years of affordable housing history, lots of deals all over the country. The loss rates on affordable housing deals that are well structured is minute. Right? It makes the death rates from coronavirus look really, really high. So what we can do in these kinds of situations is tell people, hey, by giving us a guarantee, you can unlock capital from investors that are otherwise going to be too scared to come in, and you can allow us as a foundation or as a source of mission-related money to really make sure that our contribution gets multiplied many, many times. So by doing a $1.5 million guarantee, these folks unlocked a $15 million capital stack to do affordable housing deals in their community. That's a really powerful intervention. So just close with a couple of slides about the opportunity. These problems are big enough that they have to be collaborative. They cannot be solved by a single department of an institution or by a single institution alone. And so if you're not working across departments and sectors, invite a friend to coffee and figure out what you can do together. If you're not putting equity at the center of these discussions, given all the previous discussion that you've had today, then you're not taking on the legacy that has created the conditions in which we're working. And what we find very often is that a desire to move quickly sometimes gets in the way of putting equity in the center. That's something we have to be very mindful of ourselves. We're really eager to solve the problem, and what that means is we sometimes cut short the kinds of community consultations that make it real. And so I would just caution people to say, hey, you know, sometimes you have to go slow to go fast. And so if you have not already built those relationships with the community, take the time to do that, because you will benefit from it in the long run. The third piece is the slogan from the 1960s, but it's still true today: nothing about us without us. It's not about community engagement. It's not about having people inform your decision. It's about empowering people to make the decisions with you. And if that means that we have to help people understand what are the trade-offs in the end between this kind of financing and this kind of amenity, then we need to do the work to have people understand what those trade-offs look like. It's not good enough to just say to people, what do you want, make an idealistic plan, and then pencil out everything when it gets down to the financing. And that is a pattern that we unfortunately see very, very often. We need a shift in business as usual. These are not expert silver bullet kind of solutions. These are solutions that have to come from the people who own the problem. And so bringing divergent perspectives together and having the patience to build the trust and the relationships that will cause these solutions to work is really important. So what can you do? The first thing is multi-sector collaborative. There, I believe, are in Austin already some of these things moving. If you're attached to one, great. If you're not attached to one, figure out how you can contribute. Figure out specifically what the priorities are, how many, by when, where, and with whom. Assess the ecosystem, try to figure out what are the strengths, what are the weaknesses, what would it take to achieve the priorities that we've set. Look at the pipeline, look at the resources that you can help to unlock by doing this kind of capital stacking that we talked about. Look at the roles that you and your organization can play. This is not about advising others. This is about owning a share of the problem and fixing it. And last, start. We find a lot of perfectionism in a lot of places, and it's great to be conscientious, but this kind of activity is learned by doing. So take a step, reflect on the step, and then take another step, but get started. Okay, thank you.
Well, thank you both so much. One of the things that you mentioned there at the end, Robin, that I was struck by, particularly in a room that is as diverse as the one in which we're in now in terms of folks from different industries, was this emphasis on cross-sector collaboration. One of the organizations that my lab supports helps people do their taxes, claim refunds, build financial plans while they wait in this trusted, frequented space of a doctor's waiting room. How that came about was more or less serendipitous and from the advice of one of my patients. I'm curious to hear from your perspective, how can we better systemize these interactions between industry players that just aren't typically working together? Examples of that, is there a process rather than hoping that we make friends at the table with someone from a different industry today?
So our experience has been, I don't know if that's on, our experience has been that you have to create an ongoing platform for these discussions. It's not enough for it to be bilateral, and it's not enough for it to be occasional. So what we say, and this is what we were doing here 6 years ago, is you invite the stakeholders that you think are relevant to solving a particular problem to have a discussion. You see who wants to play, you set a goal together, and then you set a cadence of meetings and responsibilities, and you get moving. So it's useful to have it be multilateral, and it's useful for it to be an ongoing process. These things are things that take time.
How about you, Ruth? Any take on that?
Yeah,
as well?
and I agree. And it has to be with the mindset of not business as usual, as you called it, Robin, in that, each of our sectors has its own culture and a way of doing something. And I think a lot of the times, certainly you're talking about healthcare, we're not in the same rooms, we're not in the same conferences, we're not having casual conversations with people from community development. And so it has to be sort of to learn to be a little outside of your comfort zone to reach in. So I think it's sort of some of the, I did some work many years ago on emotional intelligence kind of work, and having those approaches to be able to think about your assumptions, your biases, and your communications to sort of make those interactions go smoothly. And as Robin said, to have the opportunities, ongoing opportunities to develop that relationship, because so much of this is relationship-based.
So what we find, just to give you an example, we're working in Cincinnati with a Catholic hospital. And the folks that they've invited to the table include a community development financial institution, some developers, some of whom are local, some of whom have not worked in Cincinnati before, the local foundation, and the Port Authority, which was very surprising. Turns out the Port Authority has some land in the neighborhood that they're interested in and has, as part of its mandate, economic development. Economic development doesn't happen if you don't have workforce housing, which is part of what they're working on. And so sometimes, and the hospital is there, as I mentioned, and there are banks. And so sometimes you have to really think about who touches the problem in an obvious way, and then also who are the kind of less obvious stakeholders that could be relevant, and what could each one contribute? Because if they're just coming to listen, it doesn't help you.
Yeah. I'm also struck that there has to be certain pipelines of funding that you must align some of those priorities with. You think about it in the nonprofit space, there's this concept of we get these great intentions and then we go to a funder and they want something slightly different, and so we change our intentions along the way. Do you see that affecting the work that you do, especially at these large system levels where perhaps there's a leader who is less engaged with the priorities that the collaborative has put together, but you really need their buy-in?
So we have a saying, we have t-shirts in fact, that resources follow coherence. And it has been our experience that if you get together a multi-stakeholder group and you clearly define priorities, and then you go to a bank or to a foundation or to the state for that matter, and you say, look, this is what we're trying to accomplish, and here's what we need, then you get more money than you know what to do with, because it turns out when you have the money, it's very difficult to make the decisions about where to put it. If you see something that has momentum and legitimacy and clarity, then it really becomes hard to say no. So I'll give you an example. San Bernardino is one of the places that we're working with Dignity, which you mentioned. And one of the exercises that we did in the program was we had each team identify who was one stakeholder that should be at the table, who's not. And then we had them practice what's the pitch that you would make to that stakeholder about why they need to be involved. And so they were working on affordable housing in San Bernardino. And the stakeholder that they identified was a state agency called the Strategic Growth Council. They went to the Strategic Growth Council, they invited them to a site visit. They had at that site visit 45 different stakeholders that were involved in this discussion. And the state saw that this was a moving thing, that there was a lot of commitment, and they got a $20 million commitment out of the state. They had never had a relationship with these folks before. Now, you know, does it happen every time, $20 million, one meeting? Not so much. But they almost dropped dead from surprise because, you know, they had never had the experience that this is something that they could do. And when they got it together and they had a cohesive narrative, it worked.
And I think to just add to that, I mean, what Robin's referred to as this coherence and importance, I think, you know, the community engagement is an important foundation from that. And that when you have that solid foundation of the lived experience informing what you're doing, it just makes your case stronger from the get-go, so that you're not coming in with the classic sort of outside solutions to the problem you've defined, but you've identified something that matters in the community, and that I think helps gather your momentum to sort of get people on board.
Yeah. I didn't think I wanted that t-shirt when you first said it, but maybe I have to get one now.
Yeah.
We are going to move on into the questions from all of you with the Slido, as you can see up there.
Oh, yeah.
Excited to hear from you, and so I'll wait as you're typing those in. I got one directed right at you, Robin.
Yeah,
So maybe
take that one.
Take that one to start.
Yeah, so where do these things start? They start with somebody who's passionate about making a difference. So we have 2 of the 6 healthcare systems where it's a clinician, and one is an emergency room doctor and one is a pediatrician. I think that's actually not all that surprising. They're on the front lines of delivering care, and they really started the ball rolling. Sometimes it's a community foundation that sees its role as ministering to the real needs of the community. Sometimes it can start with a CDC or with an invitation. JP Morgan Chase or Wells Fargo or other banks have grant opportunities that collaboratives can apply for. And so somebody will see that and say, you know, we really ought to be doing this. So it can be a lot of different places. It helps if the convener is neutral and is perceived as being, fair and willing to listen.
Public health institutions can form a really useful sort of neutral ground between some of that sometimes, sort of a lot of data, a lot of intimate knowledge of the community and the health issues, but not really directly tied to the healthcare side, but maybe, as a sort of a convener around that. That can also help.
I'm also struck I'll get to that question, I promise. Oh, now they're coming in. I'm struck by the diversity of the places where you work. In other words, you mentioned Boston Medical Center, you mentioned Kaiser Permanente in California. There's a certain politics there that might differ from where you are in other states. Have you seen that play into your work in the types of coalitions you're able to build and the type of interventions you're able to push forward?
I think that there's no doubt that there are regional variations in conditions and policies that set up that might facilitate or make things easier. But I think that my feeling is really that there is a national realization that this kind of approach is something that is needed and the time is now for it to move forward. So I don't think that it's necessarily just a sort of a progressive kind of mentality that's bringing that. I think it's really just because the evidence is that it works so well. And because we've accumulated so much evidence of the importance of place in things like healthcare and the importance of place in education. So I think that that's really sort of, the facts are really kind of unequivocal. I don't know what you think, Robin.
Well, we work in red places, blue places, and purple places, and the general advice that we give to people is focus on what's possible. And what's possible in different places will be different depending on the context. But San Bernardino has a Republican mayor who thinks affordable housing is, from Cuba. And, there is not municipal support for the activities that are going on, but there is foundation support and there is the health industry support. So you take the support from where you can. We're working in Central Appalachia, and what is different there is the language and who comes to the table. So in California, the state is a very relevant actor. In West Virginia, the state is the least relevant actor. And so you adjust who you're spending time on based on what you think you can get accomplished.
The people are speaking, so I'm going to read the questions. Land from school closures here is being considered for affordable housing. What kind of process would you recommend in the city moves forward with this plan?
So there is a wonderful organization called 21st Century Schools that has a great deal of experience using public school land for the development of affordable housing. One of the things that they have learned, I think, through hard experience is that you want to split the goodies in ways that combine market rate, which pays for a lot of stuff, with affordable housing, which benefits the folks that we're trying to benefit, with some money for the school district, which makes them much more willing to play ball. And so there's an allocational decision, but having schools redeveloped for affordable housing is a great thing. And one of the things that we often encourage people to do is to inventory underutilized land of all kinds, whether it's owned by transit authorities, by public schools, by other municipal entities. We're working with a water utility, hospitals. Publicly owned land or public purpose land is a fabulous asset. One of the things that we've learned through hard experience is don't necessarily donate it. Make sure that it is ground leased with appropriate covenants that keeps it affordable either in perpetuity or for the very long term.
I got a good question I just came up with. What are other institutions that you see are not being tapped that could be a great partner in providing housing options?
Actually, I'm doing a project with Evidence for Action, which is another Robert Wood Johnson funded foundation based out of UCSF, and they're really sort of looking at other institutions that can take on this sort of what we call the sort of anchor role of the investments, and they're really trying to entice business, large business, in the Bay Area,
Some of the large tech companies have definitely got involved with this, most recently, solving the problem that some say they helped create. But it's sort of, Facebook or Google, these large institutions are definitely making large investments. And working alongside, Kaiser Permanente, as Robin has mentioned. So there are other institutions. It doesn't have to necessarily be. Universities are also taking up a lot of that role as being able to contribute to economic development as well as sort of housing development.
Mm-hmm. Transit authorities, electric utilities. What you would do with each of them is different, but anybody who's place-based and who has a mandate to think long-term about the health of a place is a great partner.
Good development partners, nonprofits, for-profit developers. Any thoughts on that one?
The fact that they would be mission-oriented developers is really important. So for nonprofits, you tend to see that more automatically, but there are good mission-oriented for-profit developers. The unsolved problem, which I think there's a lot of potential in, is the smaller niche developers, because in some cases working on 3, 4, 10-unit properties is both a solution for housing and it's a wealth creation and job creation mechanism. And so if you can figure out what does it take to get working capital, bonding, other kinds of necessary financial tools to the smaller developers that act locally, particularly if they're developers of color who may not have the kind of personal wealth that other developers have, that really can help you in multiple respects, because the bigger developers tend to work on the bigger developments, and that leaves a whole segment of the housing market pretty much undertouched.
Top question up there is asking about wages for low and paid employees at hospitals, other opportunities for credit building and financial coaching around the country in hospital settings. I'll say just quickly, in the organization I referenced earlier that does the tax prep, started out at Boston Medical Center. And as we started to build this collaborative now, we have about 38 partner organizations in 23 states and DC now. I'm very interested in this concept, but really, really immature in terms of the development of some of these efforts within the hospital walls. There's a good example up in San Francisco, another in UCLA, but I think it's just starting to see some of these financial health efforts at the core of addressing some of these social determinants in these settings. And so to answer the question, at least in my experience, I don't know very many, but I think that there's a groundswell of folks that are interested in trying to figure out how to integrate these types of works.
There is an organization called Health Leads that does work around the country on many of these issues. They're terrific.
I was just trying to think. There was also, but I'm blanking on it, doing mixed income housing, so making sure that it was a hospital system doing mixed income housing to sort of address the fact that, sometimes when they do housing, what they're sort of really targeting the higher paid employees, so they'll have it for their physicians, but to sort of really pay attention to the whole breadth of the community, the hospital employee community, and sort of really address that by making it mixed income housing.
I'd be curious to get your thoughts too. One of the big issues that we find in medicine is that we have all of these resources out in the community, and I can refer to every single one of them, tell them the address, figure out how to get there, and the follow-through rates are still really low because people are facing a whole host of barriers that we all know very well. It seems like there's a movement too of starting to co-host or integrate within health systems. Is that my misperception, or is that something you're also seeing? And where do you think that's headed? Because we're going to run out of space in hospitals before too long.
Yeah, I think some of this experience I've had, specifically in the working in the Department of Public Health, in San Francisco, was really, that focus on, particularly when was working in a program trying to address health in the population experiencing homelessness, and there was there's a physician there, as another street doctor, as you call it, who said, that appointments are the enemies of the homeless, that, the best intention to tell someone to be somewhere at 2 o'clock on a Tuesday is not the reality in how many people live their lives. So I think there is some sort of gaining knowledge of sort of having sort of almost stewards of making the process work around the patients a little more than the patients having to sort of ping to these usually disparate sort of departments to be able to get the sort of care that they need. Co-localizing is one of them. I guess also having sort of transportation, and maybe again it's referring to that rethinking our process and our system of how we do it so that it's more amenable to people might be another way of approaching it.
And a good segue into the top question up there too, highlighting near and dear to my designer heart, the idea of elevating folks' lived experiences as we design some of these collaboratives. Are there examples that come to mind that are best practices for how to do that, or examples that are out there that are doing that really well that we should try to model after?
Yeah. Robin, do you
Not enough.
Not enough.
Yeah.
I mean, we see typical models of building community advisory boards. The work that we do, we try to have co-founders be from the communities experiencing the problems we're trying to solve alongside, at least at UT, the students that are building some of these companies, and we've seen that being powerful. The medical school has a call for ideas, which is put out into the community to figure out what people are trying to solve, and then how do we bring them in to empower them to be able to do that in a different way than before. But you're right, there's not enough.
Yeah,
That
I mean,
seems to be a
generally
core part.
what we find is that for the hospital and health systems to be interacting directly with residents is usually not as good a solution as for the hospital to be interacting with resident organizations. And so whether those are churches or existing immigrant groups or other places where people are already organized, the power dynamic is not quite as unequal then. And so that, in our experience, tends to work out a little bit better.
Yeah, and it's really what we heard earlier today, you know, of it not just being a representation of the voice, but a power feeling of involvement in it, rather than sort of, you know, that term of sort of really incorporating people into the process and the solution, rather than turning out to have a voice and then kind of, okay, thank you very much for your input and goodbye. And I think that sort of, you know, really again, it's all part of the strengthening your case and strengthening your solution is by really incorporating a feeling of silence.
Yeah, I think that's
Agency.
right. And you know, it reminds me, one of our hospitals, which you'll see will remain nameless, said, you know, we care very much about what the community wants. And so they hired a firm to go ask the community what it wants. And the community told them what it wants, but the community was rather annoyed to be asked. And one of the reasons that they turned out to be annoyed was that over the last 40 years, they were asked 8 times. And there were 8 reports with exactly the same priorities in each of the reports, and nothing had actually changed. And so one of the things we now say to people is, before you go annoy people and raise expectations, you know, what are you doing to show that you have some understanding of what's come before you? Because for people who have lived history in a place, you know, they didn't just wake up one morning and say, oh, wouldn't it be great to have a dialogue with the hospital?
Yeah. What happened the last time we had a dialogue with the hospital, right?
Maybe we have time for 1 or 2 more questions here. Popular demand, thoughts on the use, enforcement of community benefit agreements.
And the possible changes to that. Yeah.
What we would like to see goes well beyond community benefit agreements. So is it better to have one than not to have one? Yeah. The scope of what you can often find in a community benefit agreement is as though the institution is doing the community a favor, which is not really how we look at it. So what we would like to see is that investment in the community gets baked into all the different processes. And so you can start with a community benefit agreement, but that tends to put the community on one side and the institution on the other. And part of what we're looking for here is how do we get to the same side? So whether that's engaging their own lower paid employees and understanding what does it take to reduce turnover, which is a painful and expensive thing for hospitals, but the turnover often comes from needs not being met for the lower income employees. So look for the places where the interests really do feed each other.
And I think we'd like to sort of see that movement upstream, that really sort of attention to the social determinants and that sort of deeper investment in changing infrastructure, changing environment, and addressing some of the legacies of the sort of injustices that we've heard about today, and sort of making that a deeper sort of commitment to rather than just, ticking a box, as it were.
Last question here before we wrap up. I don't know if you knew, but it's election season. And there may or may not be some policies out there that could help support addressing the social determinants of health. What's your favorite? Let's hear what we should all be voting for come November.
Oh gosh, I definitely, I try to avoid it just because I like to keep my blood pressure low and nice. And, I think that ensuring that people have access to health care and nothing like a pathogen like the coronavirus to sort of remind us all how important it is to be able to have access to health care and screening and testing. I saw a tweet, I was just telling someone earlier, that I saw a tweet that sort of was saying that we are really only as safe as the worst insured person without any sick leave availability is the level of all of our protections, so that it comes not from the bottom, not from the ceiling down, but from the bottom up. And I think that's a great reminder that we are all in health together, and there's nothing like a sort of a little infectious disease to remind us all how it's important. Health equity is for everyone's safety. So I think anything that would support that is my opinion. I'm trying to be bipartisan here.
Robin, final word.
I would say two things. One is we underestimate the extent to which there is actually agreement on how we need to do this. Because if we do what we're doing now, it's going to bankrupt society. I think Ruth mentioned that we spend more on healthcare, but less on social services and meeting human needs than any other developed economy. And so what we see by comparisons internationally is that when you put those two things together, you get better outcomes if there's more on social services and less on reactive healthcare provision. So getting more for less is not a democratic idea as much as it's a let's do what makes sense kind of idea. And I think it needs to be phrased that way. I think the other thing is a lot of these issues are issues of income and wealth. And we then subcategorize them into housing and education and all the things that flow from it. But in the end, people need to be able to earn a living. And if they can, with dignity, then health follows from that. So let's look at the policies that it takes to allow people to earn a living.
Yeah. Back to where we started with little Chloe. Help me thank Ruth and Robin for their expertise and passion.